Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on the physicians and practitioners who are redefining medicine through their integrative, functional, and holistic approach to health and well-being.
We are pleased to welcome Dr. Joseph Lamb, owner of the Personalized Lifestyle Medical Center in Gig Harbor, Washington. Thanks for joining us on Redefining Medicine.
Thank you for inviting me.
So you were traditionally trained in internal medicine, and you now practice integrative, holistic, and functional medicine. What is the difference?
The difference really comes down to how you approach the patient. William Osler said many, many years ago that it's more important to know the patient who has the disease than the disease that the patient has. It's this kind of global view of looking at the person as a whole and understanding that. And it's taking the step of digging in a little bit further and understanding, what their wishes are, what their goals are. If health is more than the simple absence of disease, then it becomes the opportunity of exploring their trajectory in a way that helps them be what they want to be.
Yeah, in researching for this interview, I was on one of your websites, and you talk about there's 4 basic tenets that underline health. Can you talk about those, please?
Yeah, well, one of them, they're kind of our beliefs that we put forth. One is that wellness is more than the simple absence of disease. Basically, coronary artery disease, a heart attack is not diagnosed the day you wake up. You weren't perfectly well the day before that. And so, it wasn't like the blockage didn't exist. So if you have a heart attack that morning and suddenly have an ICD-10 diagnosis, you've missed a real opportunity to have made a difference for that person in their life. So that's one of them. Number 2 is really the recognition that this is a partnership. One of the 4 P's is participatory, but, we really can't know as practitioners what someone's health goals are. And, when it comes to behaviors, it's hard to judge a behavior from a good or bad perspective because behaviors in different contexts have different values. So, we could all probably agree that, none of us should ever smoke a cigarette. And that's a behavior we'd all could agree that would be bad. But a certain diet may well be indicated for a person and a different diet not. And that's going to be based upon their individuality. It's going to be based upon their genetics. It's going to be based upon their preferences. So working with that person, you would want to choose what's most appropriate for them and what they're most interested in working with. So, that kind of participatory piece. Another piece is that, lifestyle interventions, whether it be, the food that you eat, the exercise that you do, the kind of work you do, and whether you like it or don't like it, and then your relaxation practices, whether it's a mind-body approach or whether it's a religious or spiritual practice, these probably represent one of the greatest potentials to influence your health. We've done clinical work here back when this was the Functional Medicine Research Center, research work then and clinical work now and research work now. You can't overcome the consequences of a bad lifestyle, even with the most potent of nutritional or botanical interventions or even pharmaceutical interventions. So one of the biggest things that we can do for someone is to show them the power of their lifestyle. And then what I would say is the 4th is, how do you assess a patient? How do you try to understand what's going on with a patient? Heart disease, for example, atherosclerosis is not a statin drug deficiency. It is a progression to having heart disease, for example. And, you really miss a lot if you're superficial in your testing, insulin resistance, which is a great contributor to coronary artery disease. If you wait for someone to have an abnormal fasting blood sugar, you've missed all those years of hyperinsulinemia. You've missed those years of postprandial blood sugar elevations. So if you change your focus and change your understanding and make it a disease-based, function-based approach, see where the pathophysiology is and align your testing with it, you have a lot that you can offer the individual person who's coming into your office.
Yeah, so the key seems to be to try to intervene in that window of opportunity before somebody kind of turns the corner on a disease process, as opposed to perhaps what some allopathic physicians do is kind of wait until you're into that next range, and then they can prescribe a medicine. Is one basic difference here?
Yeah, absolutely. I mean, for years we've said that obesity causes diabetes, but really obesity is one of the early signs that you see of changing physiology. People are probably, and if you look, the average person who's obese is insulin resistant. They may not yet be diabetic, but it was the insulin resistance that led to the hypertrophy of their fat cells, of their lipocytes, the adipocytes, and this creation of a physiology. So, the kind of debate about whether you can have a healthy, quote, fat person, not to be disparaging, but, healthy fat, you're only healthy depending if you're looking kind of superficially. But the deeper you dive into the physiology, the more you see that changes have already taken place.
The patients who come to see you, I've interviewed a lot of different doctors who are going through the fellowship training at AFREM over the years, and they're going through fellowship training because they're looking to change the way that they approach patient care and change the way that they practice, and they've gotten a reputation, and patients come to see them because, well, a couple of different things. Either they for wellness and prevention, or they've had a problem that no one else could solve, and they're frustrated. Can you, and oftentimes these doctors are the last resort. Can you give us an idea of the patient population that you serve?
Our practice is relatively new here in Gig Harbor. At the moment, I'm seeing the complex cases. I'm getting a lot of people who have already been to see an integrative and functional practitioner, and they haven't gotten to the end goal. Some of those have been referred by the practitioners themselves, and some have been referred by the patient. They found their way to us. And just like when I was in Nashville practicing with Dr. Houston, a growing portion of my practice is patients telling their families and friends.
So you currently are the principal investigator of Lifehouse, a lifestyle intervention and functional evaluation, a health outcomes survey. What's that all about?
Going back to the statement, health is more than the simple absence of disease. If indeed we believe that, right? If that's kind of a tenet that we're going to hold, then why do we all define health by disease markers? Like, what diseases do you have? Or, what risk factors for diseases do you have? Or which of these biomarkers do you have? If we start thinking about health as our ability to do the things we want to do, then it starts becoming about function. And maybe we should be trying to define health by functionality. So it's a topic that we've been interested in here at the Personalized Lifestyle Medicine Center by Metagenics, and they were nice enough to sponsor a fairly large study. Jeff Bland is on our advisory board. Lyra Heller's on our advisory board, Brent X on our advisory board, and the practitioners who were involved in the first go around of this study were Dr. Michael Stone, Dr. Deanna Minnick, Monique Class, who's a nurse practitioner, and Dr. Michelle Leary Chang, who's a naturopath, and myself. And we saw about 400 individuals and got genomic data and got microbiome data, got exposome data, did nutrition physical exams, and started these people down a path to learn some lessons. And we're still in the process of evaluating the data, and there's going to be some interesting things coming out of that. But part of it influenced just the way we thought about behavior, because there are people who reduce behaviors to make it as small and as simple as possible. And if you get the person to do it, it'll crowd out bad behaviors. But it's really focused my thinking about how do you motivate someone. And now in Lifehouse 2.0, the second kind of generation of this study, we're looking at how do you redesign the office experience to make a difference for people. We're opening a test clinic down in Aliso Viejo, California. We're designing software applications that practitioners can use, not only to manage all of the complicated data, but also, to provide education back. Of course, COVID has changed the way we all practice. And for many of us, people aren't sitting in our exam rooms for extended periods of time or the waiting room. But imagine if you could make that experience tailored to them so that during their downtime, they got some education. Or imagine that you as a practitioner at the end of it, at the end of a visit could have a discussion, this participatory, personalized discussion with the patient to do something preventative. And you said, I'm going to have you have this pathway for your health, and it's going to include multimedia presentations coming to you through your device every week for the next 8 weeks, and kind of help them make those behavioral changes. And imagine you took it to the step even further, that this software that helped you manage your patient's information, in following that patient's information longitudinally and in collecting that information. Imagine if you could start using, like, from a statistical point of view, a principal component analysis, and said, is there a group of people that can be defined by certain features that had a certain outcome? And your patient, imagine the software could get, in the next 5 to 10 years to the point where the software would say, your patient looks like these other groups. And practitioners like you have tried, program A, and some have tried programs B, and some have tried program C. And in an aggregation of all of this N of 1 data collection, imagine if it could say the best outcomes for people just like your person, on the, the components of their function and disease risk did best with this program. I mean, the tool that would offer all of us. And, a lot of work is going into this. Clinicians, nutrition scientists, software engineers, geneticists, genomic scientists, we're putting a lot of effort into this to try to see if we can't make that interaction between myself as a practitioner and the person on the other side of the desk more valuable.
Well, that sounds like a fascinating research, and definitely a program that will help practitioners communicate better with their patient and get better outcomes perhaps. Thank you for joining us today. We really appreciate your time.
Thank you. It was great to be here and great to share some of the things we're doing at the Personalized Lifestyle Medicine Center.